Hello, good morning, everybody. Today I'll be teaching you human anatomy. The topics we are covering is mouth, pharynx, and larynx. Myself, Ikra Aslam. So, what is oral cavity or a mouth? It is first part of our digestive tract. Everything we eat go through our mouth. It is bounded by cheeks and lips. Contain the tongue. As you can see in the diagram, we have lips, cheeks, teeth, gums, everything. We will be further dissecting every part in upcoming slides. Then we have lips topic. Lips are muscular structure formed mostly by orbicularis muscle. We have the muscle that forms lips, and the color from the underlying blood vessel can seen through thin transparent epithelial, giving the reddish pink appearance. When we see the color of lip is mostly pink due to the blood vessel present beneath it. Then we have tongue. Tongue is a large muscular organ that occupies most of the oral cavity. Frenum is a thin fold, like tongue is the like it will occupy almost all space. Then we have frenum, a thin fold of tissue that is attached entirely to the floor of the mouth. As you can see in the diagram, frenum of the tongue, it is it is touching the floor of the mouth and tongue. A tongue moves food in the mouth and it cooperates with the lips, cheeks, holds and food in place during mastication. As you know, when we eat food, tongue helps us very much, and uh, we can taste by tongue, and we can do when we speak. A tongue is very important part in it. It is a major sensory organ for taste as well as being one of the major organs for speech. As I told you before, it have taste buds which help us to sense the taste of the food, and it helps in speech. Then further we will talk about taste areas on the tongue, on the human tongue. Beneath we have sweet from the violet color, then salty, sour, and in the green we can see bitter. These are the taste you can see, like we feel taste like that. Next topic comes teeth. A normal adult 32 teeth. We have 32 teeth in a mouth, 16 upper, 16 lower. Then we have divided into four quadrants. If we put an imaginary line between the central incisor of upper jaw, the right portion is upper right and left portion is upper left. Same we will do from the lower jaw. As you can see in the figure, we'll put an imaginary line between the central incisors, and the left side is lower left and right side is lower right. We have central incisors. In each quadrant, we have one central incisor, one lateral incisor, and one canine, and two premolars, first and second premolar, and three molars, first, second, and third. Third molars are called wisdom tooth because they usually appear in person in late teens and early 20s. You will mostly see wisdom tooth after 18 years. Then we have teeth. The teeth of adults are permanent or secondary. When, as you know, we have permanent teeth and secondary teeth, or you can also call it primary teeth or deciduous teeth. Most of them are replaced of 20 primary and deciduous teeth. In adult, we have 32 teeth, but in child, or we can say when we have deciduous teeth is 20. Each tooth consists of root, a crown with one or more cusp, and neck and a root. As you can see in the upper portion of the tooth, which we can see when we open our mouth, is crown. But beneath it is a root. Okay. And the cusps are the projections that we can see, like horn-like projections. As you know, this cusp, it's lying there. Okay. And this is the root, as you see. Root is beneath, it's inside the bone. Then we have pulp cavity. Pulp cavity, as you can see here, it is blood vessels, all the nerves, arteries, veins here. The center of the tooth, pulp cavity, a center of a tooth which is filled with blood vessels, nerves, connective tissue called pulp. Then we goes to dentine. You can see in yellowish color this. It is dentine, a living cellular bone-like tissue surrounding the pulp cavity. It is living cellular. It is bone-like but not bone. Then we have enamel, an extremely hard acellular substance covering the dentine of the tooth and crown. It protects the tooth against the abrasion. This is the enamel. Enamel is very hard. Then we goes to cementum. Cementum can be seen in the root area. In root area, we don't see enamel. We directly see cementum, then dentine. Cementum is the covering of the surface of dentine in the root, which helps anchoring of the tooth in the jaw. It helps in the anchoring. It makes the tooth stay in that position. Teeth are the rooted within the alveoli along the alveolar process of the mandible and maxilla. Same thing, it is staying in the alveolar processes, the alveolar bone of mandible and maxilla. The alveolar processes are covered by dense fibrous connective tissue and moist certified squamous epithelium, referred to as gingiva or gum. So, the alveolar process or our alveolar bone is covered by fibrous tissue that is our gums and we call it gingiva. The teeth are held in place by periodontal ligament. Periodontal ligament you can also see in the root. This pink color is periodontal ligament, which are connective tissue fibers and extend from alveolar walls and embedded into cementum. Next, if we go to our next topic, which is palate and tonsil. We have two types of palate present in our oral cavity, which is hard palate and soft palate. If we come up to hard palate, it is the anterior part that contains bone. As you can see here, if you touch your tongue upside, you will feel the hard palate, and then comes beneath it, we have soft palate. We have uvula. First, we will do soft palate, the posterior portion that contains skeletal muscle and connective tissue. This will only contain skeletal muscles and connective tissue, but not the bone. Then we have uvula, a posterior portion of soft palate. As you can see this hanging, it's uvula. The palate separates the oral cavity from the nasal cavity, prevents food from passing into the nasal cavity during chewing or swallowing. Then we have tonsils. Tonsils, you can see this projection, bulk-like projections behind the uvula. It is tonsil, are located lateral posterior walls of oral cavity in nasopharynx and posterior surface of the tongue. Then if we go to next topic, which is salivary glands, we have parotid, submandibular and sublingual glands. We have three. They produce saliva and which is mix of serous and mucus fluids. Then we have saliva. We all know saliva helps in keep the oral cavity moist and contain enzymes that begin the process of chemical digestion. Saliva makes our oral cavity moist, which also helps in enzyme and chemical digestion. Our whole digestion system starts within the mouth only. The salivary gland have bunching ducts with clusters of alveoli, resemble grapes and the end of duct. When we see alveoli together in the salivary duct, it resembles as grapes. As you can see, the grapes are in bunch. This you can see Here is our parotid. First, we'll see parotid gland. Here is the parotid gland near our ear. Okay, it is mainly near our TMJ, temporal mandible joint. Then we have parotid duct, the duct that comes and opens in our oral cavity. And the muscle that is beneath it is masseter muscle. Then we have submandibular gland. Submandibular gland is at the down of our mandible. Okay. Then we have sublingual gland. Sublingual is below our tongue. We also have the ducts of submandibular duct. We have tongue. If you go next slide, now we will study in detail the salivary gland. And our serous gland located just anterior to the each ear. It is located anterior to our ear here. Then we have parotid duct, enters the oral cavity and adjacent to upper second molar. When the parotid duct opens, it opens to adjacent to our second upper molar. Okay. Then we have submandibular gland, produce more serous than mucus secretion. The submandibular ducts open into the oral cavity on each side of the frenum of the tongue. We have more serous and mucus secretion. We have both secretion here, but more serous than mucus. Submandibular ducts open in the oral cavity on each side of frenum of the duct. When you put your tongue upwards, you will see the frenum, but at the side of the frenum, we have ducts. Then we have sublingual gland. It is the smallest three-paired salivary gland, produce primarily mucus secretion. Here the mucus secretion is happening, little bit serious but not much component. Then we have lie immediately below the mucous membrane or in the floor of the oral cavity. It just lie below the mucous membrane on the floor of the cavity. Each lingual gland has 10 to 12 small ducts opening onto the floor of the oral cavity. We have 10 to 12 small ducts that will all open to the floor of the oral cavity. Then we have next topic. We are going to the next topic, which is larynx. It is the muscular cartilaginous structure lined with mucous membrane. Why we are calling it musculocartilaginous structure? Because it is the combination of a cartilage and muscles. We don't have bone here. It is lined with mucous membrane, and the protection is done by the mucous membrane. It is connected to the superior part of trachea and to the pharynx. The essential sphincter guarding the entrance into the trachea, and it also guides into the trachea. Then we have functionally secondary as an organ of voice. It is also known as organ of voice because if we are talking, it is helping us to uh, put the sound, as it have voice box also, vocal cords. We have Next we have it is formed by 9 cartilage connected by ligaments and 8 muscles. Begin at the level of the vertebra 6-4 and 6-5 and ends at the level of vertebra 6-7. If we see vertebra, we have named of the vertebra cervical. So it starts from cervical 4 to cervical 5 and ends in the level of vertebra 6-7. Then we see the anatomy of larynx. First, we will come to anterior view. What you see? A epiglottis, a flap-like structure, leaf-like structure. Then we have hyoid bone. Then we have laryngeal prominence. As you can see this part, it is laryngeal prominence. Then we have thyroid cartilage, which also protects thyroid gland. Then we have cricoid cartilage. Then we have trachea, and this is tracheal cartilage, which is protecting trachea. This whole thing is larynx. If we come to the posterior view, what we see different is vocal ligaments, which is helping in voice. We have arytenoid cartilage, same. And then if we come to sagittal section is the cross section. Then we will see hyoid bone, we see epiglottis, we see thyroid cartilage, adenoid cartilage, and cricoid cartilage, tracheal cartilage. Let's go to next slide. We have cartilages. We have 9 cartilages of larynx. 3 are paired, 3 are unpaired. Unpaired is thyroid cartilage, cricoid cartilage, and epiglottis. We have paired adenoid cartilage, corniculate cartilage, and cuneiform cartilage. Then we will come to thyroid cartilage. The largest laryngeal cartilage, also known as shield shape. It forms most of the anterior and lateral wall of larynx. The thyroid cartilage, when viewed in the sagittal section, incomplete posteriorly. The anterior surface of the cartilage bears thick ridge and the laryngeal prominence. This ridge is easily seen and felt. The thyroid cartilage is commonly called Adam's apple. Then we will see the cartilage. As you can see, shield shape, and it have horns. This horns you can see, these are horns. This is superior horn, this is inferior horns. Horn-like projections. Then we have, uh, okay, this is laryngeal prominence. This is anterior, posterior, sagittal. Inferior horns make synovial hinge joint with cricoid cartilage. Laryngeal prominence is apple or more prominent in males. As you can see, Adam apple that we can see, it is more prominent in male. Then we have cricoid cartilage. It is ring-shaped cartilage, complete ring whose posterior portion is greatly expanded, providing the support to the absence of thyroid cartilage. Forms the most of the posterior wall of larynx, and cricoid and thyroid cartilage protect glottis in entrance of the trachea. Next we have cartilages. Okay, this is anterior view and this is ang of cricoid. This is cricoid. Okay. Then posterior view, as you can see, this is lamina of cricoid. Ring shape, complete of ring cartilage has narrow anterior and broad lamina. Then we will see the cartilage, which is epiglottis cartilage. This you can see the flap, leaf-like structure. Leaf-shaped cartilage posterior to the root of the tongue connects to the body of hyoid and posterior side of the thyroid cartilage. Then we have paired cartilage. We have arytenoid cartilage, corniculate cartilage, cuneiform cartilage. Okay. This this purple color is cuneiform cartilage. Green color is corniculate cartilage, and this red is arytenoid cartilage. It is arytenoid cartilage, pyramid shape cartilage above lamina, have synovial joint with cricoid. Then we have corniculate, nodules above the arytenoid in the arytenoid epiglottic fold. Then we have cuneiform, rod shape above the corniculate cartilages. Next slide. Then we have extrinsic ligaments of larynx. Connects cartilage of hyoid and trachea. We have thyrohyoid-like ligament links to larynx and hyoid. Then we have cricothyroid ligament links thyroid to cricoid. Then we have cricotracheal ligament links cricoid to the first tracheal cartilage. This you can see in the diagram. The median thyrohyoid ligament. Then we have median of cricothyroid ligament. This red one, and blue one is next slide. We will go to next slide, which is intrinsic ligament. Connects cartilages to each other and forms the internal frame. First, we have quadrangular membrane links from arytenoid to epiglottis form the vestibular ligament. We have concus electricus forms vocal ligament framework of vocal fold, which is true chord. Then we'll come to the cavity of larynx. Cavity of larynx contain vestibule and folds and vocal folds and a glottis. These vestibule folds and vocal folds divide cavity of the larynx into three compartments, which is superior vestibule, sinus of the larynx, and subglottic space. If we come to glottis, it is a vocal apparatus of larynx, makes us vocal fold process, and together with rhima glottis, we have vocal fold, which is also known as true vocal cords. These are the sharp-edged fold of mucous membrane, source of the sound from the larynx. They produce audible vibrations and act as sphincters when tightly adhered. When we will speak, it will produce vibration which we able to hear. Then we have vestibular fold, also known as false vocal cord. They are protective in function. They will protect, they will not produce any voice. No function in voice production. They become swollen when anaphylactic shock cause suffocation. Because they are protecting. If you are suffocating, they will get swelled. Then we have intrinsic muscles of larynx. We have abductor of the vocal cords, posterior cricoarytenoid. Then we have second abductor of vocal cords, lateral. We have tensor and abductor of vocal cords, opener of the laryngeal inlet, and closer of laryngeal inlet. These are the muscles that will help in the opening and the closing and abductors. Next, if we go to extrinsic muscles, these are divided into two groups, cervical muscles and pharyngeal muscles. Cervical muscles, we have suprahyoid muscle, which act as elevator of the elevator of larynx. Then we have infrahyoid muscles, which strap muscle, which act as the depressor of the larynx. Then we have pharyngeal muscle, includes inferior constrictor muscle. And these are the muscle you can see in the diagram. This is thyroarytenoid muscle. This red one you can see. This will vocal ligament decrease the pitch. It relax and decrease the pitch. Then we have muscle of larynx. We have arytenoid. We have lateral arytenoid, cricoarytenoid. This blue one you can see, and the purple one is posterior cricoarytenoid, subductors and vocal folds. Now we will go to the next slide, which is nerves of larynx. It is branches of vagus nerve. We have 12 cervical nerve. It comes from the vagus nerve. Superior laryngeal nerve divided into internal laryngeal nerve, sensory to the laryngeal above through vocal folds. As you can see here, superior laryngeal nerve, inferior laryngeal nerve, this external laryngeal nerve, and recurrent laryngeal nerve. Then we will go to external laryngeal nerve, motor to thyrocricoid. Then we have recurrent laryngeal nerve, which is sensory to the larynx below true vocal folds and the muscles. Now we will see arterial supply. Superior laryngeal artery. Here it is superior laryngeal artery. From superior thyroid artery. Then we have inferior laryngeal artery. Here it is inferior laryngeal artery. From inferior thyroid artery. Now we will see lymphatic drainage. Superior deep cervical nodes, larynx above true vocal folds. Here you can see above true vocal folds. Now we will see inferior depth cervical nodes below the true vocal folds. Here. Now it is laryngoscopy view of larynx. If we see through the laryngoscopy, how we will see our larynx? We have tongue, epiglottis. This is epiglottis, vestibular folds. This is false vocal folds. This is true vocal folds. This one. It is open and this is the closed view of larynx. Now we'll go to laryngoscopy grading. First we'll go to grade 1. All the structures visible. Grade 2, only posterior part of the epiglottis visible. Grade 3, only epiglottis seen. Grade 4, no recognizable structure. Now our next topic is pharynx. Pharynx is a fibromuscular tube. It is common challenge for both food and air. Location behind the cavity of nose, mouth and larynx. This is behind the cavity of mouth, nose, pharynx. Here, this is the cavity of nose. Behind it, you will see your pharynx. It is shaped as funnel shape, extend from the base of the skull to esophagus. These are the dimension. Length is 12 to 14 centimeter. Width at the base 3.5 centimeter. At pharyngo esopharyngeal junction 1.5 centimeter. This is the more less complex view of pharynx. Now we will do the boundaries. Superior, the base of the skull, the posterior part of the body of sphenoid and basilar part of the occipital bone in front of pharyngeal tubercle. Inferior, continuous with the esopharyngeal at the level of lower border of cricoid cartilage and anteriorly to below to the border of C6 vertebra posteriorly. Then we will see posterior, prevertebral fascia anteriorly opens into cavity of nose, mouth and larynx. Laterally, neurovascular bundle of neck, stylo process with the attachment of muscle and ligaments. You can all refer to this diagram, this important diagram. Here you can see these are the ligaments we're talking about that are attached. These. Now we will see two subdivisions. These are divided into three. Pharynx is divided into three parts, which is nasopharynx, oryngopharynx, and laryngopharynx. Location of the nasopharynx. If we start from nasopharynx, it will, if it behind the concave posterior nasal apparatus and below the soft tongue. This is a concave. Okay. Communication entirely with nose nasal cavity and inferiorly with oropharynx. Next, we will go to nasopharyngeal isthmus. It is an opening bounded entirely by the soft palate and posteriorly by posterior wall of pharynx. This is also known as passivant ridge. As you can see in this diagram, the air will enter from this, from the nasal cavity, but the food will enter from mouth. When it will go, now it is here, it is both, like both are connecting. This will go to uh, esophagus and this will go to trachea. Here we have epiglottis, which helps not help the food not to go in our air way. Next, features: nasopharyngeal and pharyngeal tonsils, orifice of pharyngotympanic tube, which is also known as our auditory tube, tubercle elevation, tubercle tonsil, selfingo-pharyngeal fold, and selfingo-palatine fold. Pharyngeal recess, also known as fossa of Remuller. Then we have nasopharyngeal and pharyngeal tonsils, a collection of lymphoid tissue. Here you will see a collection of lymphoid tissue, and the location is at the junction of roof and posterior wall of nasopharynx. It contains nasopharyngeal brusa. Nasopharyngeal brusa is a pouch of Lukshuka. A mucus diverculum which extends upward into the substance of pharyngeal tonsil from its apex. It develops due to the adhesion of notochord to the dorsal view wall of pharyngeal part of foregut. Here, if I make you understand one diagram, okay. This is tongue, okay. We have muscles of tongue, genoglossus, genohyoid, mylohyoid, hyoid bone, Okay, this is a mouth. Okay, and this is nose cavity, nasal cavity. Air is going here, and the food is going here. So, which is helping is this epiglottic fold, which helps food not to enter into the airway. We have vocal folds here. Now we'll go to auditory tube. Our auditory tube. It is location wall on lateral wall of nasopharynx, approximately 1.25 centimeter behind the inferior nasal concha. Tubular elevation, upper and posterior margin of orifice of the tube, and elevation due to the collection of these elevated margin are known as tubercle elevation. Elevation is a collection of lymphoid tissue. In tubal elevation is also known as tubal tonsil. Next slide, we have self-pharyngeal fold, a mucous fold which extends vertically towards the side wall of pharynx from tubercle elevation, contains self-pharyngeus muscle, as you can see here. This self-palatine fold. Then we have self-palatine fold, a mucous fold which extends downwards and forward to the smooth palate from tubercle elevation, contains levator palatine muscle here. Okay, this is self-pharyngeal fold. This is self-palatine fold. Then we have pharyngeal recess, also known as fossa of Rosen-Mule, Rosen-Mule, where we have, there it is. This you can see the small pit, it is pharyngeal recess. It is a deep depression behind the tubercle elevation. Now we'll see applied aspects. We have adenoids, enlarge of nasopharyngeal tonsil due to infection or block the posterior nares. Then there is infection or something, it will get uh, inflamed. We have clinical feature, nasal obstruction, nasal discharge, mouth breathing, snoring, protrusion of the tongue, toneless voice, small nose, epistaxis, which is known as nose bleeding. Nasopharyngeal tonsils are prominent in children up to age 6 years. They gradually undergo atrophy at the puberty. They completely disappear by the age of 20. This is the pictures that is shown, which is adenoid phases. It is also known as long face syndrome. Long and open mouth phase of the children with adenoid hypertrophy. The children are obligatory mouth breathers. They mostly breathe with mouth. Present mouth breather may be associated with the development of craniofacial anomalies. Craniofacial anomalies, when there's a mouth breather, we can see the difference here. We can see it is very overbite and it's mouth breather. So they're more anteriors, upper anteriors are more prone to be more outwards. Then which will characteristics of facial appearance consist of underdeveloping their thin nostrils, short upper lip, prominent upper teeth, crowded teeth, narrow upper walls, high anchor palatine, and hypoplastic maxilla. This is the pictures, and this is nasopharyngeal swab. It has also been seen in COVID times. Thank you so much for your attention.